All right, everyone. Thank you so much. We're going to kick this off. We see some familiar faces and some friends joining. Thank you for coming back. We have lots of new folks joining as well. We appreciate you being part of our community, and we invite our physicians, we invite patients, we invite investors and advocates, and all the people that are excited about the future of cell therapy. My name is Kroom Lawrence. I'm the Chief Commercial Officer for Hemostemics. On the line, we have our CEO, Thomas Smink. We should be joined with our Chief Medical Officer, Dr. Fraser Henderson, momentarily. I have an eye out for him to join. And I'm just going to have some quick introductory remarks, and then we'll dig into the presentation. By way of housekeeping, uh, we would welcome your active participation. So please raise your hand, add questions to the chat. We typically go 30 minutes of content and data, 30 minutes of Q&A. We're going to allow a little bit more time for Dr. Henderson to go over as needed. If you'd like further follow-up, please type interested in the chat and we'll get back to you directly if you'd like to request a follow-up call. We'll send out a recording to all registrants, and also please look for the Hemostemics channel on YouTube where we are posting the recordings. I will just share my slides and we will dig in here. I may not be able to see you after I have shared, so please forgive me. Um, and 1 second, I think it is this one. Yes, I think that is right. If I'm not able to see what's happening in the chat, you'll forgive me. I think that should be coming through. If it's not, just give me a quick shout out. That'd be greatly appreciated. We're going to recap just very briefly from last week. We're going to have a clinical update from our Chief Medical Officer, Fraser Henderson, talk about recent publications and clinical studies and what's coming next. And then we'll talk about some new things at the end that we're rolling out constantly to improve care and help our physicians and patients understand how and when it's appropriate to consider Vescel, which is an investigational therapy under development that is not approved by the FDA. But access to this investigational therapy may be available in Florida or other states pursuant to state laws for eligible patients who provided informed consent and have been advised of the investigational nature of the treatment. Information in this webinar is for educational purposes only and should not be considered medical advice or promotion of an unapproved product. What we discussed last time and I'll just be very brief here so we can get on to the presentation, is the role and value of SimCell therapy. It really is focused on the growing global health span gap. People are living longer, but they're living sicker longer, and that's often a function of the Western diet and all the things that everybody worries about. Cardiovascular disease, diabetes, Alzheimer's, all top causes of morbidity and mortality in North America and in states where we are interested in improving care, like in Florida. And until now, stem cell care had been pushed offshore. And in a recent FDA roundtable on gene and stem cell therapy, there was a considerable emphasis on bringing this capability back onshore and regulatory pathways to do that. And so there's a lot of complexity. The sick care model really only reaches a small number of patients. We unpacked this a little bit last time on the challenges of poor adherence, even if there is a medication, around cholesterol, heart disease, hypertension, diabetes, etc. There's so many barriers to taking medications. Adherence is still a struggle for so many. A lot of people show up too late with more severe disease that is costly. There is a recency effect. Even my father, who had a heart attack in January, had no idea that it was coming, has gone back to the Western diet. Shout out to Dad there. But it's hard to maintain discipline as we confront the Western diet issues. High cost, unnecessary morbidity and deaths. And we're looking at and following continuous government and public support for cell-based therapies. I just pulled some numbers. There are several thousand gene and cell therapies, 4,400 in development. 22% of them are cell-based therapies. And around the world, 33 gene therapies, 35 RNA therapies, and 71 cell therapies are approved globally as of the first quarter of 2025, which is, we think, very encouraging. We talk a lot about critical limb ischemia. Last time we covered what that is as one of the most severe forms of peripheral artery disease, characterized by rest pain, non-healing ulcers, and gangrene, affecting 1 to 2% of PAD patients, with high risk of amputation, which is about 20 to 40% within a year, and 20 to 25% mortality risk in year one, which is something that we're focused on trying to correct. We talked a little bit about vascular dementia last time also, which is a function of reduced blood flow to the brain caused by a stroke. And as of mid-2025, the industry focuses on symptomatic management, vascular risk reduction, and emerging research into regenerative therapies, and that's us. There's a role for us in that space. Finally, we talked a little bit about computer-brain interfaces last week. And Dr. Henderson, I'm just going to tee this up if you're there. Let me just check everyone to see our roll call here today. Just one moment. I want to make sure Dr. Henderson is with us because I can't see. One moment, please. I would like to do a quick introduction. 1 second. Thank you, everyone. Do I see you here, Dr. Henderson? Are you with us? Not yet. All right. Dr. Henderson is a practicing physician and our chief medical officer. He may have been called away if there's a medical emergency or a surgical procedure, which happens with our good friend. But I'd like to make a couple of comments on his recent publication in Cell magazine, which is really an incredible breakthrough and a discovery. One of the absolute most amazing science fiction-y things happening today are brain-computer interfaces. You'll think about companies like Neuralink. There are at least 10 others and many startups looking at embedding devices into the brain that help translate neural signals into actions like controlling cursors, speech, and even prosthetics. So a recent presentation by Neuralink talks about embedding devices in the brain as well as into a limb or into a prosthetic so that the patient or the individual can control the prosthetic with their thoughts. There are now 9 human implants as of today, enabling thought-controlled computing and robotic arms. And really, what is the challenge that we're focused on is what happens if the fidelity of that device, of the implant, is reduced due to scarring or inflammation or some loss of fidelity in the electronics to gather the signals. And so Dr. Henderson has published a paper on that. The science is incredibly interesting. If you have not seen it or read it, I would encourage you to go. We'll send out the link afterwards. And I will, I think now I'm going to go into the rest of the presentation. Hopefully Dr. Henderson will be able to join us momentarily. But I'm going to carry on with our talk. If there are any questions or anything in the chat so far, I'm going to quickly go over to Q&A, and I'll just look there for a moment. Okay, so I'm going to go back to our typical discussion of our work being rolled out in vascular disease and in Florida. So let me just click over to that for now. And you will bear with me as I pull up the deck again. And here we go. So we've talked a lot about the burden of care, gaps in care, and we've talked about the essential partnership between our regulatory partners, our medical partners, and then how we really help the community. How do we provide education, services, support in the context of an investigational therapy? And Dr. Henderson, and we've previously covered our clinical studies where our soon and up and coming phase 3 trial for critical limb ischemia will give us access to FDA approval, to payer reimbursement, and to making this therapy more broadly available, considering that the mortality rate is so high, up to 25% within 1 year. And for individuals where revascularization is not available, or if there's been a failure to apply stents or an amputation is imminent, there is significant interest in finding new options, and that's where the mechanism of action of ACP-01 comes into play. I'll talk about that in 1 second. So what is clearly important about autologous stem cells, because as it comes from a patient's own blood, there is less immunological rejection. There's no risk of any contagion or contaminants coming from somebody else's blood. And so there is significant safety that we're seeing in individuals that have taken ACP-01, reported in our phase 1 studies, of which we've had 5 published. And so that gives us, increasing interest and further validation in our clinical pipeline, where we will extract and enrich the desired cell population, inject the cell populations, essentially to form new blood vessels to help regenerate dying tissue from a patient's own blood, simple blood draw that could really occur anywhere, and a 7-day, very fast turnaround to re-inject stem cells back into the patient, into the calf, in the case of a critical limb ischemia, which we've seen in the phase 2 study. We cover that data, typically every webinar that we have every week, to continue to unpack that, to help just continue to communicate, in what kind of patients it's working in, and patients where it may not be as effective. The mechanism of action for Vascular is around new blood vessel formation, cell migration to the areas of need, healing and regeneration, and an anti-inflammatory effect that helps to down-regulate inflammatory signals to help reduce pain and prevent further tissue damage. So these are the effects that we're looking for in our studies and looking for in self-report from patients. But it's also important that we provide a complete care program. So it's not just about the injection of the stem cells. It's about having a comprehensive diagnostic workup. It's about a personalized wellness and recovery plan. It's about long-term monitoring and support. The wellness and recovery plan, we think is so important, as the Western diet is still at play. That is still, one of the causes of disease. So we can't take our eye off the ball just in general of bringing health back to our patients. The diagnostic workup is also very insightful, and especially in the case, as we talked about last time, of our future phase 1 study in vascular dementia using AI-powered cognitive testing, where we'll have the most accurate ability to track and measure cognitive changes, often referred to as mild cognitive impairment, so we can see very subtle changes in memory and cognition, so that as treatment takes effect, we can see how fast onset is, also the durability of cognitive improvement. Ideally, we can demonstrate that. One of our patients that has taken it, she was remarkable. Thomas often speaks about our patient number 1, who 10 years later is sharp as a tack and has done well. That warrants further validation in our clinical studies. That has given us a lot of excitement that there is a promise that we can work towards for vascular dementia, where there really are no other options and significant burden. Finding ways to save on Vascular is absolutely essential. We're working very hard every day to demonstrate every possible way we can help. One of our most important things, which I love the most, and I think Thomas likes, is our support for those most in need and the 501(c)(3) Foundation. For individuals that can afford Vessel out of pocket, we would encourage you to please buy a second one for someone in need who may not be able to afford it. That's what the foundation's for. We're focused on generating financing solutions that have low monthly payments, and then reserving your treatment through our treatment convertible debentures is also, we think, a very important way to participate in the life of the company, to reserve your treatment, and to get into queue as supply and manufacturing in our FDA-approved facility rolls out this year and into 2026. I will just suggest for patients and physicians on the call, if you would like to talk about our wait list, compassionate use, or payment options, please reach out to me. For medical affairs, reach out to Fraser. And for investors or any other questions, please reach out to our CEO, Thomas Smink, on the line. I'm going to pause there for one moment and just check and see who we have, and hopefully Dr. Henderson has joined. If not, I would love to see, Thomas, if you want to say anything, and I'm giving you, I'm unmuting you.
Sure.
And if there's any other questions from physicians or patients or investors, oh, Fraser, Dr. Henderson has joined us. That is very exciting. Yes.
I'll let Krim, your email contains his presentation. So if you wouldn't mind pulling that up, then if you could unmute Dr. Henderson, I'll just say a moment, or a few words, and then ask him to introduce himself. I first was introduced to Dr. Henderson by my wife, Sandy Smink. And when Dr. Henderson kindly offered his expertise and time to come to Canada and speak to neurosurgeons on the condition of Ehlers-Danlos syndrome and Chiari malformation, and I had the distinct pleasure of picking him up in Buffalo and driving him back from Oakville. And it was then that we discussed Hemostemics, and that was some 13 years ago, I think now. And when I came back to the company in late November 2019, I thought of asking him to assist in moving the company forward, and he graciously accepted, and has been working with us now for the better part of 4 years, and going on 5. So without further ado, Dr. Henderson, if you could introduce yourself and take us through your perspective of our technology.
All right. Thanks, Thomas. And I have to say, it's a real privilege to be working with people like Thomas and Krim, who are really both top in their field. I'm a practicing neurosurgeon professor at University of Maryland, adjunct professor. And so let me run you through the medical perspective here and of what I think is a very exciting new technology. To begin with, ACP is safe. There can be no question about that. It's obtained, the product's obtained from a simple blood draw in the office. There's no anesthesia involved, no complications associated with a bone marrow harvest. The public perception of it is excellent. There's no risk of any unusual or tainted blood products. Very importantly, unlike some of the more primitive cell types, there's no risk of neoplasia, like the pluripotential cells have that risk of forming a cancer. Not so with the autologous ACP cells. There's no ethical concerns as there are with fetal tissue. And maybe the most important thing is that there's no risk of transmissible spongiform encephalopathy, like you heard about mad cow disease. The equivalent in man is Jakob Creutzfeldt, and there are others, and they have a very long latency, and so it's almost impossible to diagnose in a donor. So the first time someone develops a Jakob-Creutzfeldt encephalopathy from stem cells will be the last time that anyone uses allogeneic products. So there's no risk to medical providers with this autologous product, ACP. Next. Now, there have been 7 published studies on ACP, and which encompass 298 patients. In fact, 500 have been treated, and there have been no complications related to the cell itself. Only a patient with a silent MI that was unrecognized, and I'll discuss him later. Next. So today we'll discuss very briefly cardiac failure, ischemic cardiomyopathy, and non-ischemic dilated cardiomyopathy. And we're talking about 1.6% of the population. And once hospitalized with heart failure, 42% of those patients will die within 5 years. And similarly with critical limb ischemia, also known as chronic limb-threatening ischemia, we see same numbers of people, about 2 million in the US. Once diagnosed, there's an amputation rate of almost 20% at 1 year, or maybe more than that, mortality rate of 50% by 5 years. And then we'll discuss briefly how ACP and NCP might be used in the new AI, or the brain-computer interface, and also for vascular dementia. And today we won't be discussing the utility with neuropathic pain and traumatic head, leukoencephalopathic dementia, other things that we're looking forward to. Next. So there's some excellent preclinical work, which I won't go into now, next, but I'll touch on in what I have to say. In this study by Aram with 20 ischemic patients and 21 dilated non-ischemic cardiomyopathy or heart failure patients, we saw an improvement of the New York Health Association in the functional class, p-value of 0.05, improvement in the 6-minute walk test, 126 meters, and the ejection fraction improved by 5%. So the ejection fraction is the amount of blood, for the non-doctors, it's the amount of blood pumped out with every heartbeat. And normally the normal person pumps out 60% of the blood volume of the heart with every heartbeat. These patients had an average ejection fraction of 30%, which is half normal. And we saw an improvement here of 5% on top of that 30%, which is very significant for that population. Next. And in this study of 106 patients, we saw highly significant improvements in the Canadian Cardiovascular Score, the NYHA, and again, ejection fractions. Next slide. And in this study of intractable angina, again, highly significant improvements in the Canadian Cardiovascular Score, the 6-minute walk. And we saw the perfusion defect, that's the area of heart not getting enough blood, decrease from 38% to 21% at 6 months. Next slide. And in our most recent study of 53 patients, next. If we look at the patients at 4 months, if you look at the middle column, the left ventricular ejection fraction increase, like the other patients, it was 4.6% at 4 months, but it increased at 12 months to almost 7.7%. Now, that if you look at 7.7% as an increase in the overall ejection fraction, that's an improvement of cardiac efficiency of 27%, which is huge, and with a very highly significant p-value. And if we break this into ischemic heart failure, there's a 24% improvement in overall cardiac efficiency. But the non-ischemic dilated cardiomyopathy, and these patients were all lining up for heart transplants, by the way. That's the category of patient. They had a 47% improvement in cardiac efficiency. Next slide. So breaking this into quartiles, the far left, we see patients with an ejection fraction of less than 20%. And that's really, really a low ejection fraction. And the second group, 20 to 29%. These two quartiles, they're at high risk for developing a sudden arrhythmia and dying. And they showed a huge improvement from, you see the red pre-treatment and the yellow at 1 year, and a very significant overall improvement in their ejection fraction. Next slide. And the quality of life studies were not very complete, but 2 out of 3 patients reported an improvement in quality of life. Now, the complications, one patient had a silent MI 2 weeks before the transplantation procedure. No one had known about it, and that patient died from the procedure. 2 patients with, very rapid heart rates, tachyarrhythmias, needed cardioversion, the electrical cardioversion. Next. So we are looking into obtaining an orphan disease category for idiopathic dilated cardiomyopathy, which is a population of patients we think, which we have shown respond best to the ACP. And that's an ongoing debate with the FDA right now. Next. So critical limb ischemia, or chronic limb-threatening ischemia, is about 11% of patients with peripheral arterial disease, and that's 12 million to 20 million Americans have peripheral arterial disease. So there are about 2 million with critical limb ischemia in the United States. And that population is much more frequent as you get older, or the prevalence is much greater in the later years. Now, the 6-month amputation rate, 10 to 40%, and 6-month mortality rate, 15 to 20%, and 50% at 5 years. So it's a really deadly diagnosis. And the country spends over $200 billion a year taking care of these patients, especially with diabetes, $120,000 a year to take care of a patient with diabetes with critical limb ischemia. Medicare data. Next. So Szabo looked at a phase 2 study of 22 patients. These were no option candidates. They were not candidates for endovascular revascularization or opening up of the blood vessel or for surgical revascularization. And at 2 years in the treated group, there were no deaths, 3 major amputations, and they all had improved pain, improved wound healing, and walking ability, compared with the control group in whom there were 2 deaths and 6 amputations. So a big, significant difference. Next. And in Mudaranga's study, smaller study, there were no complications. 83% showed improved distal circulation, 80% complete healing of ulcers. Next slide. And then the study we recently published it was a randomized controlled study of 12 centers across North America. And these patients similarly were not candidates for surgical revascularization. They were very severe CLI patients. Next slide. Now, when we look at those patients who presented with wound issues like that foot ulcer, upper right picture, and we followed them, the treated group were in blue, the controls are in orange, and at 6 months, there was a significant improvement, highly significant improvement in wound healing of the treated group, no improvement in the control group. Next slide. And perhaps more importantly, the number of amputations in the treated group with ACP was 4.8%, and the death rate 4.8%, as opposed to the placebo group in which the amputation rate and the death rate were 25%, the latter being comparable to US Medicare studies. Next. So how does ACP work? Why do these cells achieve this? Well, ACP are programmed specifically to form blood vessels. They're not like, say, mesenchymal cells, which can form anything from fat to bone to nerves to blood vessels. And they're kind of all over the place. It's kind of a shotgun approach with a mesenchymal stem cell. The angiogenic cell, however, is like a rifle, and it has a precise target. It forms a blood vessel. It also releases vascular endothelial growth factor, that VEGF, and the angiogenin, and the CXCL8, it's interleukin 8, all of which promote angiogenesis. Now, very importantly, the ACP is not just one type of cell. 1/3 of the ACP have the CD34 plus marker receptors. And these strongly promote angiogenesis and tissue repair. And moreover, the CXCL8, interleukin 8, recruits additional CD34 cells from the periphery. So the wound may be in the foot, but injured cells and the ACP in particular will attract further CD34 cells from the rest of the body. Next slide. So this is the kind of interleukin 8 upregulation we saw with ACP as compared to a control. Very high levels of interleukin 8. This is more commonly known now as chemokine ligand 8. And this, as I said, mobilizes the CD34 cells and many other things we'll discuss shortly. Next. Recently, with the first head face transplant, they attributed a lot of the success of this transplant to the CD34 stem cells. Next. Now, the animal studies have shown, and it's understood in the literature, that that endothelial cells and ACP and NCP actually express these CXC receptor 4 receptors, and these are attracted to very specifically and robustly to released chemokine ligand 12, the CXCL12, also known as stromal-derived factor 1. So injured and ischemic tissue and injured neurons and heart release this stromal-derived factor number 1, CXCL12, and that attracts the cells with the CXCR4 receptors, specifically ACP and NCP. So these cells are attracted to the cell area of interest. They home in, they embed, they release paracrine factors, and so on. Next. Now, ACP, as I said, release the interleukin 8. And this also attracts the NK cell, which is part of the lymphoid cell population. It's unfortunately named the natural killer cell. It actually has anti-inflammatory, anti-apoptotic. It's pro-cell survival, and it's pro-tissue homeostasis. So the NK cells are the cells that you want to clean up inflammation, and they are attracted by the ACP release of interleukin 8. So the presence of NK cells attracted in from the periphery decreases the scarring and decreases the inflammation, decreases the scarring, and improves recovery. So in this rodent study on the far right, these cells, the first column is the thickness of scar tissue, and these cells have decreased scar tissue as a result of the NK adoption of the M2 monocyte, which I'll discuss in a minute. And the column to the right shows much more scar tissue in the controls. Similarly, in the next two histograms, the M2 cells promote a much thicker, healthy heart wall following injury compared to the controls. So the ability to decrease inflammation and scarring is very beneficial. Next slide. Let me touch on the neural precursor cells, the NCP, that we grow, and they have typical neural cell morphology. They develop the long extensions, typical of neuronal cell cultures. Next. They have the same nestin and anti-B tubulin markers, anti-O4, and the gliofibrillary acid protein markers that characterize neurons, oligodendrocytes, and astrocytes. Next. And we see the growth in culture. It takes 2 weeks to culture these cells, and they release nerve growth factor, glial-derived neurotrophic factor, macrophage colony stimulating factor, and stem cell factor. And these are really important paracrine released factors that will stimulate the growth and health and robustness of the cells around them. Next. So our application thought process is that we're going to use these ACP and NCP for the brain-computer interface, the BCI, and also we're now submitting applications for an IND with the FDA to treat vascular dementia. Next slide. So here's the paradigm for the brain-computer interface, and I'm thinking of, we're talking about things like Neuralink. One would procure the ACP treatment and later the NCP, and then administer it through a simple lumbar puncture. This can be done in any office, and with a very small needle, so the complications from this are extremely small. These cells then migrate through the CSF, spinal fluid, to the areas of injury where the electrodes have been placed, implant and release these neurotrophic factors. They attract the NK cell to decrease scarring, and they also activate the nuclear factor kappa B, which I'll discuss momentarily, and they promote the adoption of the non-inflammatory macrophage, the M2 macrophage, which is very important. The 10% of the cells in the brain are microglial cells, and once stimulated, they become macrophages, which promote inflammation and mopping up of destruction in the brain. The M1 is ballistic and inflammatory and causes a lot of scarring. The M2 is more sedate, gentlemanly, cleans up the injured cells, and dampens down the inflammation, promotes healing. Next. So I told you that ACP upregulates interleukin 8, and interleukin 8 upregulates nuclear factor kappa B, and this is we think of very great importance. In the central nervous system, it promotes, it's anti-apoptotic, so it preserves cells, modulates inflammation, and perhaps most importantly in the BCI algorithm, it's essential for processing information, for synaptic plasticity, and the formation of memory. Next. So interleukin-8 directly activates surface receptors 1 and 2, which phosphorylate the IKK complex, which activates nuclear factor kappa B, which is translocated into the nucleus, where it results in the production of messenger RNA to produce the proteins necessary for forming dendrites, for elongating axons, and for any kind of formation of memory. It's essential, this nuclear factor kappa B. It also promotes expression of proteins which inhibit cell death, anti-apoptotic. Next. The nerve cells, the NCP, are programmed to differentiate into oligodendrocytes, astrocytes, and neurons. And they also have the influence of promoting the non-inflammatory M2 monocyte. So it's anti-inflammatory. And they also bear the CXCR4 receptors, so they migrate toward the release of ligand CXCL ligand 12. So they migrate to areas of injury. Next. And this is just the nuclear factor kappa B again. Next. So we think these cells are going to be exceptionally appropriate for treating vascular dementia, a problem that is going to affect about 2% of everyone over age 65. Next. And the 4 types of vascular dementia: post-stroke, subcortical, multi-infarct, and a large number that are mixed with Alzheimer's and other neurodegenerative disorders. So it's vascular dementia is not a homogeneous group. It's there's a bit of a range of pathology here. And I think we're going to find a subgroup like the subcortical vascular ischemia that's going to be particularly improved with ACP and NCP. Next. There's no medical treatment that is effective for vascular impairment and dementia. Next. We're writing up a study for 100 patients from USA and Europe, but we've also written up a smaller phase 1 study that we hope to achieve in a short period of time through an IND process and quickly get onto the phase 2 study. I've no question that will demonstrate the safety of performing these injections, and I think that even in the first study, the phase 1 study, I think we'll be seeing some efficacy. Next slide. So in this paradigm of treating vascular dementia, we'll aspirate. If you look at the upper left corner, we draw the blood, we form the ACP, and then 10 days later the NCP. These cells are injected into the spinal fluid. The spinal fluid passes upward. It's a closed system of 120 to 150 milliliters. So it's trapped around the brain, and it flows around the blood vessels within the spaces of Virchow-Robin throughout the brain. These cells do not have to cross the blood-brain barrier, and they will circulate, find the areas of increased ligand, CXC ligand 12, and home in there and release their paracrine factors. Next. And next slide. We've already demonstrated that the NCPs will home to damaged retinas, as shown here in one animal study. Next. And also in another rodent study, the cells migrate to areas around infarcts. Next. So in conclusion, it's clear that ACP is safe in over 500 patients, appears to be very effective in both ischemic and non-ischemic dilated cardiomyopathy, heart failure. It significantly improved ulcer healing and decreased death and amputation. We think it's going to be very effective in vascular dementia and also for the brain-computer interface. And we think the ability to upregulate expression of the nuclear factor kappa B, that it's going to promote healing and ultimately provide the perfect substrate for the AI brain interface. These cells migrate to injured regions, repopulate. They have powerful paracrine effects, stimulate angiogenesis and neurogenesis, decrease scarring, inhibit apoptosis, cell death, and very importantly, increase neural plasticity in the injured CNS. So thanks for your attention. Hope I didn't talk too long there.
Thank you, Dr. Henderson. Let's go to Q&A. Let's quit sharing. Thank you for joining us. Sorry, I went on probably a little bit too long. I hope I didn't crowd you out, but thank you for unpacking all that for us. I will, Thomas, if you want to jump in with any thoughts, that's great. Otherwise, I will look at the Q&A and we'll see what we can talk about with our guests here. Let's see here. Dan, thank you for your kind words. Asking about a potential cancer application, Dr. Henderson.
Well, I can envision that, but we haven't really thought much about that or done any work in that respect. So down the track, I could see an application, for instance, improving blood flow in cancers to make them more sensitive to radiation therapy, for instance. But that's something we haven't looked into.
It's a lot on the plate. Let's see, Crystal. Thank you. Yes, I'll make sure there's a replay for you. We'll post it on our YouTube channel, put it on the website, and I'll send you a link as well. Thank you, Crystal.
All right, well, enjoy the rest of your summer. Take care. Thank you. Bye-bye.
Let's see. Nothing else in the Q&A. Let's give it a 30 seconds or so and see if there's any other questions. We are so lucky to have a smidge of time with you, Dr. Henderson. And we'll just stand by for a moment.
Would encourage people to read that new manuscript we just published in Cells.
Mm-hmm.
It's a bit long. But it covers a lot of these biomolecular issues that I think explain the efficacy of these cells. And it's available online, so they don't have to pay for it.
Okay, thank you. I do see a question. You said the needle is quite small, so it's not very painful.
It's a very small needle, and it would not be, you numb up the area, would not be painful, and the risk of a spinal fluid leak from one of those small needle point, of what they call pencil point 25 gauge needles, the risk of a CSF leak is minimal, like much less than 1%.
And Thomas, I think you've referred to a blood draw being like, if you're donating your blood, it's a typical blood draw that most people have probably.
Indeed.
Okay.
Yes, an outpatient procedure as well, which is one of the features of Hemostemics that make this a very scalable technology and a very scalable company. As compared to a bone marrow extraction, which is an in-hospital procedure that requires not only physician time but hospital time. The blood draw is a procedure that can be done in a physician's office as we know, we donate blood in many office buildings, so it's an everyday procedure.
Okay, thank you. Chris, thank you for your question. You spoke about a phase 1 trial of 100 people. When do you foresee this beginning?
In the new year,
Mhm.
hopefully in December. But
Mhm.
a phase 1 trial, the actual trial of phase 1 study will be smaller than 100. We'll be treating 100 patients that will not necessarily fall within the strict guidelines of the phase 1. So we'll be looking at a number of different types of or variations of dementia, and probably in Switzerland and Toronto and in the US and maybe the Bahamas. But the actual phase 1 study that we submit to the FDA will be a smaller part of that.
Thank you. Thanks, Chris, for your question. I don't see any other questions on our chat right now. We can just stand by for a minute, or if there's anything else. Let's see. Sorry. Thank you, Chris. Is interleukin-8 a cytokine? Does it create inflammation?
Yeah, it's a powerful chemokine, and it's a little bit depends a little bit on the environment and what's happening. But in the brain, in the central nervous system, it's predominantly anti-inflammatory. But in other situations outside of the brain, it could participate in inflammatory reactions.
All right. Thank you. Let's see. Nothing else yet? I'll stand by for a moment.
I'll make a comment with respect to Florida and the Krum. I know you touched on this, that Florida, as of July 1st, has recently passed legislation that permits non-FDA approved stem cell therapy for the treatment of pain on the basis that the physician stays in his area of practice. And that really offers a commercial avenue for Hemostemics. Krum, you're on board to really lead that charge, and the opportunity is very significant. Number one, to help those patients who are suffering in pain from diseases like angina or critical limb ischemia, which is on a pain scale 10 out of 10, and that really does offer a both the patients and Hemostemics an opportunity to treat patients in the USA, in the state of Florida legally. So we're gearing up for that. And then, of course, the other point I think is worthwhile mentioning is that the FDA conducted a roundtable recently and outlined under new leadership really a change in focus. RFK Jr. described how he's responsible now for $1.3 trillion of annual healthcare spend in the U.S., the largest single budgetary item in the federal budget. And in his view, how the standard of care today is really not working, both from a fiscal perspective, but also from a patient perspective. And they was quite open to cell and gene therapy, especially autologous cell therapy, with respect to offering new opportunities of treatment to address some of these underlying conditions at the root cause. And so that is a wholesale change in the perspective from a leadership perspective. And then we saw really at the science level and at the physician level some 40 years of frustration that was very adeptly voiced, but nonetheless was right at the surface, especially in the area of orphan diseases, and especially in the area of pediatrics. And so, we have a strategy to, on the one hand, deal with the FDA on a standard, what I would say is a standard regulatory basis, but we really do fit well in the wheelhouse of offering a therapy and a path forward that is in sync with and in step with their focus on bringing cell and gene therapy to the forefront. So that bodes well for Hemostemics. And lastly, if you're new to the company, management and the board have combined invested over $10.6 million since March of 2020. We obviously invite you to join us. The value of the company is undervalued, in my humble opinion. It's we have a market cap of some $21, $22 million, when we have peers who do not have a commercial product, are in phase 2 and maybe going into phase 3, as we have in the area of critical limb ischemia, phase 2 completed a phase 3 product, and are trading closer to a $200 million valuation. So on a risk capital basis, I invite you to join the individuals on this call, as well as other directors and officers who have voted with their own risk capital.
Thank you, Thomas. A couple of really good questions coming in. I know we're down to a minute or two. You might, if you have to drop, Fraser, we understand.
Yeah, some sick patients, so
Thank you very much, Dr.
Grateful for your time.
Great to see you all. Thanks
Thank
for
you.
the opportunity to speak.
Okay, Thomas, let's try to knock out some of there's some good ones coming in here. So I think a little bit along what you were just saying is, how unique is the work you're doing, and what does the competitive landscape look like? And you were just talking about our peers. Maybe you would tackle that one.
Sure. So we really do want to step back and understand that there are two basic forms of stem cells. There are stem cells that come from your own body, and those are autologous, and there's stem cells that come from a donor, and those are allogeneic. What is unique about Hemostemics is that it is not only an autologous product, but it is sourced from the patient's own blood in a very scalable procedure. Now, uniquely, what Dr. Henderson just walked us through was the mechanisms of action of ACP once re-injected into the body, giving back to the body more of that which it needs to generate new circulation where the body signals that need. That signal is pain on the one hand, inflammation on the other hand. And so in terms of competitive landscape, in the area of heart disease, Biocardia, recently published that their phase 3 trial to improve left ventricle ejection fraction failed to meet the primary endpoint of improving left ventricle ejection fraction. At Hemostemics, we have 4 heart studies demonstrating not only do we improve left ventricle ejection fraction, we also improve the ability to exercise as measured by the 6-minute walk test. We improve quality of life as measured by the SF-36 health survey. In the area of critical limb ischemia, there is one other competitor that is completing a phase 2, has not announced the phase 2. We are interested in seeing their results as well. And so that is, the landscape at this point in time with respect to those 2 indications that we've treated some 498 patients in. In the in the area of BCI, uniquely, Hemostemics has both ACP and NCP, both generated from the patient's blood, and uniquely have the most advanced data in the world on the ability of these cell lines to home to the site of need, engraft at the site of need, and regenerate the site of need. The animal study that Dr. Henderson spoke briefly about in the NCP, the stroke model, very interesting model done in Prague. This was nude rats being injected with NCP 3 different ways with color-coded cells, 1 into the skin, 2 into the muscle, and 3 into the circulatory system, into a vein. And regardless of the method of injection, after 10 days, these animals were sacrificed and they counted the cells at the site of stroke. And regardless of the method of injection, more than 90% of the cells in each case were at the site of stroke. And so that's very indicative of the homing mechanism of both ACP and NCP.
Thank you, Thomas. I think if you don't mind, we have a couple of questions coming from Chris asking about how long does it take the FDA to respond to our applications? This is his first one.
Yep, it's 60 days.
Thank you. And then there's a question on what changes in nutrition aid in supporting ACP, NCP. What changes in nutrition aid?
Boy, that's a loaded question and a great question. And we are thinking about this in terms of a regime, if you will, or a standard of post-care that encourages people to change their lifestyle, change their diet, and improve, and thereby improve their health. And so it's not fully baked yet, so I won't get into it, but I do want you to know that we are encouraged by practitioners, including functional medicine practitioners, who are encouraging us to move in that direction and offer not just a one and done type of treatment, which all of our data is based on one ACP treatment, but really help individuals shift gears into a healthier lifestyle.
Okay, thank you. And then, Chris, you had one on how do we get this out to the world?
Mm-hmm. Yeah. Well, that's a great question. And then I'll let Kroom answer that because this is his wheelhouse and he's best equipped.
So that has to start with the regulatory guidelines around where we are as a company and where ACP is and its pipeline as it relates to phase 1, 2, and 3 studies. So we're essentially in a period of communicating and publishing our scientific evidence. We will go into a period of recruiting for patients to join those studies, all within the FDA guidance and those rules and regulations there that we follow and read every single day and understand. Then in the context of Florida, where there is a pathway now to, based on physician and patient consent, it's a matter of establishing our clinics where we can offer the treatment itself and then communicating with physicians that can identify patients in need. Because we have a specific manufacturing pipeline, we will be able to schedule those patients that really are severe, that are suffering, that are in a no option place where the physician and the patient agree that they should seek this type of treatment. And we understand how to support those physicians with education, with services, and then how to support the patients with everything they might need to understand whether this treatment's right for them, whether it's education, whether it's travel, whether it is financing and payment support, access to other things like our 501(c)(3), things of that nature. So there are different communications that are happening. A lot of that is also surrounded in advocacy and influencers and families and caregivers that have the experience. They see the evidence for themselves and they talk about it. We listen for the positives. We also listen for the negatives. We are listening for adverse events wherever they may be, and we will fulfill that requirement to report that. But we're building momentum within a really good understanding of regulatory framework nationally and state by state and globally. And that we're excited about the momentum that we're seeing so far. And engagement has been good.
If I could just add to that. So the that's what I would say is perhaps a US centric view in that, and obviously that's a number one market. So we're very much on side with that framework and are ably led here by Kroom. Internationally, there's some 5,000 stem cell clinics that offer various forms of both mostly donor stem cell based therapy for a variety of diseases. They're typically physician owned and physician led. And our pitch there is, quite frankly, we're doing this through platforms. Think of it like an Amazon platform that will have, several hundred tier one clinics. Our pitch is to add ACP to their platform, to their practice, because we have the scientific evidence of its safety and efficacy, because they can add it to their shelf and get on side of their regulator with respect to offering autologous treatments that are scientifically evidence-based. And we have a model that enables them to recruit patients from around the world to their practice, which they currently do anyway. And then we're working with very specific clinics and clinicians on the rollout of ACP in international jurisdictions. We will name those as we sign agreements. We have thought long and hard about the payment plan, whether that is, as Kroom mentioned at the outset, a therapy convertible debenture that we pay the patient 6% interest in stock on their investment in ACP treatment, while we use their capital to grow the business. Or whether it's a payment plan, or whether it's a donor that donates a treatment to a 501(c)(3) that then helps another individual in need get treatment. So we have structured the business to really expand very significantly, and do it from a pre-sale, if you will, that turns into a sale on a pre-sale basis, and then through the clinics and clinicians who have an obvious interest in offering a stem cell treatment.
Thank you. Thank you, Thomas. Okay, one last one. In light of RFK's interest in stem cell therapy, do you foresee a potential meeting with him to discuss ACP-01 in the near future? I think that's
a great question. If it's if LinkedIn has shown us anything, it is that there's 5 or 6 degrees of separation. I think he would be very interested in what we have, and I would encourage anyone within 1 degree or 2 degrees of separation to reach out to me and work with me to make that happen. It just makes sense.
Sure does. And practically, Thomas, a question: would a Canadian travel to Florida for the blood draw, or can it be done here?
So Canada has a very unique regulatory regime. A Canadian actually resident in Ontario cannot be treated with ACP in Ontario unless they have a special access application. a resident of Alberta can travel to Ontario and be treated under a special access program. An American can travel to Canada and be treated with ACP under a special access program. And then, yes, a Canadian can fly to Florida and be treated in Florida. The blood draw can be done in the patient's home by a nurse practitioner in Canada. So you can foresee that the individual will have the blood draw done in the patient's home by a nurse practitioner. A week later is in a preset appointment with the treating physician who will treat them in an outpatient procedure if it's for critical limb ischemia or peripheral arterial disease, or in a cath lab if it's a cardiologist doing an invasive cardiology procedure.
Okay. Thank you, Thomas. I think that's all the questions we have. Thank you so much, Thomas, to you and to everyone on the call. Grateful for you staying over an extra 15 minutes or so. Please join us again next time. We do these every week, and we're excited to bring you continuous news updates and information from what we're doing and how things are going. But thank you for your support, everybody.
Great to see you.
Great to see you. Have a great week, everybody. Thank you. Bye.
Bye-bye.